So hello everybody, we'll get going now. So this is a session on GI pathology today, or GI conditions, and we have the wonderful Sophie Talib joining us, who is going to take you through a whole bunch of conditions. So there's a lot to get excited for. So over to you, Sophie.
Oh, great. Thanks for introducing me. That's very kind. So yeah, I'll just crack on because there's quite a lot to cover in GI. Hold on. There we go. So gastroenterology, tea and medicine. I realise there's quite a lot of overlap with gastroenterology surgery and general surgery, so I'm not going to cover a lot of those. So acute abdomen and pancreatitis and those kind of things, I'm sure you've studied it in a lot of detail already. Okay, I'm going to have to click. It's not letting me press. All right, so I've split this session into 3 topics. We've got infections, upper GI cancer, and then autoimmune diseases. So we're going to start with infections. So gastroenteritis is a very common condition, and it normally presents itself with diarrhea and possibly vomiting. And it's the result of an infection in the gastrointestinal tract. You can also get symptoms of nausea, cramps, fever, and general myalgia. So it normally presents with diarrhea, and there's different types of diarrhea to be aware of. So acute diarrhea is more than 3 episodes of partially formed or watery stool within 14 days, so within 2 weeks. Then you've also got persistent diarrhea, which you can assume is for a longer period of time, and that's 14 days. Traveler's diarrhea, again, makes sense from what it's called. It's diarrhea that's during or after travel. Dysentery is a different type of diarrhea, and that's when you've got blood in the diarrhea, and that's also normally an infective cause of diarrhea. Another thing to be aware of is that not all diarrhea is infective. Some of them will be non-infective, so things like inflammatory bowel disease, irritable bowel syndrome, and other malabsorption disorders, and also cancer. Some of these things we'll touch upon later. Food poisoning is a different type of infection which you need to be aware of. It's infection from the consumption of contaminated food or water. And food poisoning is an outbreak or a cluster is a notifiable disease, and that needs to be reported to your local health team. So an outbreak is classified as more than 2 cases in a vicinity of the same pathogen, and that needs to be referred to your local health protection team. So there's a lot of different causes of gastroenteritis, and I've kind of split it into 2 different. I split it based on symptoms. So you've got diarrhea with blood, so that's dysentery, and then diarrhea without blood, so just watery stool. There's a lot here, and I've just taken this straight out of the Oxford Handbook. You don't need to know all of them. I've kind of put the ones in bold that I think are more important. So norovirus is very common, and you'll see it a lot on the wards. It's very contagious. And you've got rotavirus, which is more common among children. Staph aureus is another very common cause of diarrhea. Cholera, we don't see it in this country, but it is very severe, and patients can die from severe dehydration. Giardia and Cryptosporidium, they are more parasitic fungal infections. And then when you look at dysentery, so blood in the diarrhea, that can be caused by shigellosis, C. diff, which is very, very serious, and normally the result of either prolonged antibiotic use or prolonged hospital stay. And then there's also cytomegalovirus. So this page is quite a lot on it. This is just a breakdown of the main types of gastroenteritis and their main key point to be aware of. And these are the sort of things you might see in SBAs. So norovirus is highly contagious. It's really common. About a 12 to 24-hour incubation period, so it's quite short. And one of the things I decided when it came to study these things is that learning what the incubation period is going to take a lot of time, not worth it. So really, you should focus on key points for each of the infections themselves. Norovirus, but yeah, that's got a very acute onset, and people need to self-isolate when they have symptoms. And you need to isolate them, and it takes about 2 to 3 days for the symptoms to start. And I've said repeat infections because we don't seem to develop any sort of immunity to it. We seem to be able to catch norovirus every year. So yeah, rotavirus, I've said, is common in children. Campylobacter, that's another common one they like to test. It's commonly the result of Campylobacter jejuni because it affects the jejunum, and it's from undercooked poultry. So you'll see a lot we'll see higher rates of these cases during summertime when people have undercooked food at barbecues. Got Bacillus cereus is commonly found in reheated rice, so that's something you might want to look for in your SBA questions. And that's got another really short incubation time of about 30 minutes to 15 hours. Now, cholera, we said we don't really get it in this country, but you might see it in travellers. And it's transmitted by fecally contaminated water. But interestingly enough, a lot of patients will be asymptomatic, so you might not see it. And it presents with really diffuse watery diarrhea, and that is the main cause of death from diarrhea, is the amount of diffuse diarrhea. Right? And they lose loads of salts and ions from that. And you can treat it with raw rehydration salts. Now, E. coli, I think in the previous line we saw E. coli can be in both, can present with both watery diarrhea, but also dysentery. Now, there's loads of different strains of E. coli, and it's the pathogenic ones that cause gastroenteritis. It's normally a foodborne illness, and E. coli is the most common cause of traveller's diarrhea. And traveller's diarrhea affects regions South Africa, Central and South America. Sorry, did I say South Africa? I meant South Asia. Sorry, I can't read. And one thing to be aware of is that about 10% of these patients can develop hemolytic uremic syndrome. It's not common, but it presents with a triad of anemia, thrombocytopenia, and kidney failure. So anemia is low hemoglobin, and thrombocytopenia is low platelets. C. diff, we said, is associated with antibiotics and also prolonged hospital stay. It's really important to know about this one because this can develop into systemic infection and also cause toxic megacolon and sepsis. So it can be very severe. The toxic megacolon is, which we'll mention later on in the presentation as well, is really severe fulminant inflammation of the bowel, and all that swelling in the edematous bowel actually swells the neurons to the point that then they don't work anymore, and so the bowel just swells and dilates. And then when it dilates that much, it's at risk of perforation. And of course, that can lead to sepsis and ultimately death. You can also see yellow adherent plaques on the inside of the bowel, but you really shouldn't be. I mean, if you're seeing this, it means you're doing an endoscopy, which you shouldn't be, because endoscopy would be contraindicated in patients with toxic megacolon. Anyway, it's also known to have a characteristic smell. Now, I've not come across it, but I'm sure if you ask nurses on the ward, they will be very much able to tell you. C. diff is also one of those things that isn't covered by alcohol gel, so you must wash your hands. You must wash your hands to make sure you don't catch it. So Cryptosporidium and Listeria, these are two that are found immunocompromised. These don't tend to cause infections in immunocompetent patients. So anyone that has an infection from these, you might want to suspect whether they've had cancer, whether they've got AIDS, transplant, they've got some level of immunosuppression. Listeria you find in cold meats, pasty and soft cheese. I think there was a case about 2 years ago where there was listeria in the sandwiches in hospitals. Okay, next slide. Okay, so normally we don't investigate gastroenteritis. It's normally self-limiting. I'm sure we've all had it before. But if you do want to investigate it, make sure you ask in your history about recent contacts, any recent travel and exposure to contaminated sources. So we said we wouldn't investigate it, but if we thought that the patient was showing systemic signs of being unwell, or there were special circumstances, you would want to investigate. So we would do bloods, especially if you're starting IV fluids for these patients. You might see a high raised white cell count, that shows inflammation, and also high levels of hemoglobin and platelets because they're so dehydrated that as a result, the hemoglobin is raised. And in some patients, you can get the hemolytic uremic syndrome mentioned. If patients have anemia, that might suggest they've got a non-infective diarrhea, something like Crohn's or UC. You'd also want to check using these because dehydration can result in electrolyte disturbance, and you'd want to check in these high-risk patients. Creatinine would rule out AKI, and then CRP is an inflammatory marker, and also cultures if you think there might be sepsis. In terms of stool culture, we do it. It's not always needed, but there are certain cases where you would need to do it. So I've listed them in red. So prolonged diarrhea, if the presentation was slightly atypical, if they got signs of sepsis, so severe abdominal pain, if there's blood in the stool. If you've got a suspicion that it might be bacterial or non-viral, essentially non-viral, any history of antibiotic use would suggest C. diff, so you'd want to investigate that. In high-risk patients, you do want to, because you don't know. You want to be safe with these patients. You don't know what the cause might be. And yeah, again, in recent travel, systemic outbreaks, you need to test outbreaks and systemic infections. Okay. And in terms of imaging, we don't really do it unless, systemically unwell, we query sepsis. So you might do an abdominal X-ray. You might see colonic dilatation. On an abdominal radiograph, if the bowel is more than 6 centimeters, the 3-6-9 rule. If the large bowel is more than 6 centimeters, that's dilatation. You might see thickening and thumbprinting, and we can sometimes do a CT as well. So in terms of management, it's normally self-limiting, as we said. Make sure patients drink lots of water and hydrate. You can make oral rehydration therapy on your own. That's just from the Oxford Handbook. If the patient's systemically unwell, you want to admit them straight to hospital. They'll need thorough rehydration therapy and lead investigations, your standard A to E. Patients that have gastroenteritis on the ward, you want to isolate before you've assessed that, before you've got cultures and investigations, because you don't know if it's infected yet. For C. diff, if they're on an antibiotic, you want to remove that, because that's probably what's causing it. In terms of treating with antibiotics, we don't tend to, except in the case of C. difficile. So we provide metronidazole if it's mild or moderate, and in the case of severe, we give them vancomycin. And these are the parameters for that. There's evidence it can reduce the length of diarrhea in E. coli, but it's not really done. And we can also give metronidazole in some cases. Antimotility drugs are avoided, and that's because if there's a risk of colonic dilatation or perforation, there's a risk of dilatation or perforation if you give them antimotility. And important to note, patients should stay off work for 48 hours from the last diarrheal episode. So what are the complications? One of the things is that we can get reinfected with gastroenteritis. We don't seem to develop antibodies to it. And then just the usual thing, which I'm sure we've all learned in the last few years from COVID: hand hygiene, PPE. We need to isolate patients when they're unwell, so they shouldn't avoid the GP and they should take time off work. We can make sure we eat well-cooked food. Travellers need to avoid ice, make sure they drink clean water and avoid raw food. And then just, minimize, if we can, minimize length of hospital stay to reduce the risk of developing C. diff. Okay, so the key points: diarrhea can have non-infectious causes. Norovirus is highly contagious. Keep off work for 48 hours since the last diarrheal episode. Be aware about C. diff. C. diff is very common. Sorry, not very common, very serious. Uncommon infections may present in the immunocompromised, and we don't always need a stool sample. And remember sepsis. Okay, peptic ulcers. So it will become clear in the next few slides why I've put this under infection. So an ulcer is a breach in the mucosa, and for peptic ulcers, that's a breach in the mucosa of the lower esophagus, stomach, or duodenum, which fail to heal over a reasonable period of time. So that's this bit of the stomach. It's typically in the gastroantrum or the proximal duodenum. And typically, I think duodenal ulcers are more common. One thing to note is that peptic ulcers are not cancerous. Now, there are two other terms to be aware of, which are gastritis and GORD. They're related, but they're not the same. So gastritis is inflammation of the stomach, and GORD is regurgitation of stomach content into the lower esophagus. So what causes it? So peptic ulcers can either be esophageal ulcers or gastric or duodenal ulcers. And esophageal ulcers are typically caused by GORD, and these are the risk factors for GORD. We've got alcohol, smoking, coffee, and these ones lower the esophageal tone, the lower esophageal tone. So if that's reduced, then it means that the stomach contents can regurgitate back up into the esophagus. There's also stress, pregnancy, and obesity. Now, pregnancy and obesity, they increase the intra-abdominal pressure. If the pressure below is raised, that's more likely to force the acid up into the esophagus. And there's also drugs, a hiatus hernia, which I put a little diagram of here. If you can imagine the stomach contents inside, if the fundus is able to constantly push through the diaphragm, that can result in regurgitation of the stomach acid. Others want to know, like eating before bed and possibly spicy food. So for gastric or duodenal ulcers, the common causes are H. pylori, so Helicobacter pylori, and non-steroidal anti-inflammatory drugs. Also, we've got steroids, smoking, alcohol, and stress. Another thing to be aware of is that there are things called stress ulcers, also known as curling ulcers, and these are seen in massive trauma and in sepsis. And what happens here is that you get mucosal ischemia, and because there's ischemia of the stomach, that makes it prone to being damaged and getting ulcers. So how do we get peptic ulcers? It's either due to a weakened defense mechanism or an increased acid attack. And so each pylori is able to actually break down two of our defenses. That's our mucus bicarbonate layer and the epithelial cell defenses. And what it does, it's able to live in that mucus layer in the stomach, and it synthesizes urease, and urease converts urea to ammonia. Now, ammonia neutralizes that gastric acid, and that's what allows it to stay inside the stomach. It's also got its own, adhesins and cellular proteins and things that allow it to bypass the epithelial cell defenses. NSAIDs are also able to do this because, as we know, they inhibit prostaglandins, and that interferes with the immune system and the epithelial cell defenses of the stomach. And as we mentioned before, curling ulcers, they interfere with the mucosal blood flow. Now, you can also get increased acid attack, and that does happen in a rare condition called Zollinger-Ellison syndrome. And Zollinger-Ellison syndrome is where you get increased levels of gastrin, and from a tumor. So it's a tumor that releases high levels of gastrin, and that increases the level of acid in the stomach, which can lead to ulcers. So, who gets peptic ulcers? So it tends to be people in their 50s or 60s for gastric ulcers, and for duodenal ulcers in their 40s or 30s. Ulcers can actually be asymptomatic, so these patients won't present to you. But otherwise, they tend to present with epigastric pain. And depending on the type of ulcer, it will either be pain after eating, that's gastric, or pain will be relieved by eating, if it's a duodenal ulcer. They can also get nausea, fullness and bloating, and they particularly tend to get early satiety if there's evidence of pyloric stenosis, so if there's obstruction near the pylorus. You also get symptoms of dyspepsia, as you would expect. And the other thing is ulcers have a tendency to bleed, and so if that's the case, they can get hematemesis or melena. Now, melena is blood which is further down in the gut, so it's going to present a bit more of a bit more coffee ground type of vomit. And if you get melena, we know it's further down in the gut, so that's more likely to be a duodenal ulcer rather than a gastric ulcer. That's more likely to be fresh red blood. You can also get blood in the stool, but that's not very common. Now, one of the things you must be aware of are things called alarm symptoms. They're called alarm because it's a mnemonic, but also because they are alarming. These are signs that make you want to suspect cancer. So if you've got someone who's a bit older, because you don't really tend to get cancer in younger people, or gastric cancers at least, you'll be looking for anemia, L for loss of weight, maybe A for anorexia, R for recent or progressive symptoms. So if it's progressive, it gives an impression that the tumor's getting bigger and bigger and therefore obstructing the stomach or in the esophagus, obstructing a lumen. Then you've also there's melena, which is another sign of bleeding, and also swallowing difficulty. But these are more related to gastric cancer than GI cancers. But be aware of these. Okay, so in terms of investigation, endoscopy is the gold standard for peptic ulcers. Now, there are two nice referral guidelines to be aware of. So if you see dyspepsia and a significant acute gastrointestinal bleeding, you need to refer them immediately to the specialist on the same day. And that's because there could be a massive hemorrhage which they need to be treated for. Another thing is, any patient over 55 with a weight loss plus either dyspepsia, reflux, or upper abdominal pain needs to go for a gastrointestinal endoscopy within 2 weeks. And that's because in this case, we are concerned about cancer. Now, if they then go for an endoscopy and ulcer is present, you want to biopsy and test it for H. pylori, and then you want to do a repeat investigation in about 6 to 8 weeks. So, how do we investigate this? So, if you want to investigate, so the investigation really depends on how the patient presents. So, if they presented with the signs and symptoms we had earlier, we send them for endoscopy. If, however, you want to test them for H. pylori, you want to do a Helicobacter carbon-13 urea breath test or a stool antigen test. The thing to be aware of is that with this test, you need a 2-week washout period after PPI use and a 4-week washout period after antibiotic use, because these will interfere with the results of the test and can lead to false negatives otherwise. You then once you've treated it, you want to retest to make sure you've properly eradicated it after about 6 to 8 weeks. And you tend to avoid this in children and pregnant women. You might want to avoid the breath test in children or pregnant women. So in this group of people, you probably want to do a stool antigen test. Serum gastrin. We mentioned that there's elevated levels of gastrin in Zollinger-Ellison syndrome. So if you've got suspicions that might be the case, then you might want to test for serum gastrin. And these patients tend to present with symptoms of diarrhea. It's a bit odd, but that's a symptom of theirs. And you can also test for anemia if you're concerned. Or you might pick up anemia. It's more likely you pick up anemia incidentally and then refer them for an endoscopy. Okay, management. So management again depends on symptoms. So if they're actively bleeding, you want to do your A to E, stabilize the patient, and if they're actively bleeding, you might need to do a blood transfusion. You do a group and save. You can also do a Blatchford score. And the Blatchford score is a way of us assessing risk. Is a way of assessing risk of the patient bleeding and the risk of them needing intervention with endoscopy. And that looks at levels of urea, hemoglobin, and blood pressure and heart rate. And you can just Google that, and it comes up on med calculator with all the parameters. Some of these patients need endoscopy management, and that might be mechanically to stop the bleeding. Sometimes they do thermal coagulation, and sometimes they use adrenaline or thrombin to help stop the bleeding. And typically, we provide TPIs after they've had their endoscopy if they've been bleeding. And you might need to do a repeat endoscopy for some of these patients. If there's no active bleeding, we can, it again depends on how we present. Now, we can use this chart that I found on Oxford Handbook to help us. So, if they're not over 55, we don't think they have cancer, they're not going to go straight for an endoscopy. What we'll do is we'll take their history, and we might decide, you know what, they're on NSAIDs, so we'll stop the NSAID, and that might actually treat their symptoms straight away. So there's no further management needed. And you can tell them, to try some other over-the-counter antacids, do some lifestyle advice. So cut down the alcohol, cut down the smoking, that kind of thing. Don't eat so late before bed, and maybe that will solve all their problems. If not, then you'd want to test for H. pylori. And depending on whether they've got H. pylori or not, we treat according to that. So if they don't have if they're negative for H. pylori, you can start on a PPI or an H2 antagonist if they can't tolerate that. So that's something like a meprazole or ranitidine. If they do have H. pylori and they're positive for it, we start them on triple therapy. So triple therapy is a PPI, amoxicillin, metronidazole, or clarithromycin. Sorry, there's a spelling error there. But so PPI and amoxicillin. But if they've got a penicillin allergy, then we don't do that, and we do metronidazole and clarithromycin. And then we want to do, for these patients that have H. pylori, we want to do a repeat test after 6 weeks to check we are eradicated. And then those that had an endoscopy, again, a repeat endoscopy in 6 to 8 weeks to make sure it's all healed up and there's no sign of cancer. The complications, peptic ulcers can bleed, and they can be an acute, massive acute bleed where it's integrated with a large blood vessel, or a chronic bleed where it's effectively the small blood vessels. They can perforate and can lead to peritonitis, sepsis, and peritoneum, neuroperitoneum, all those things. You can also get strictures, and that's from the repeated amount of inflammation and fibrosis, and that can result in obstruction. So remember we said early satiety, that can be a symptom of that there. So I put in malignant change, which is an ulcerated gastric carcinoma, and that has a rolled edge, so it looks a bit more like this on growth pathology. The thing is, you don't really get malignant change. If you find cancer, it was always cancer, and we mistook it for peptic ulcer instead of initially diagnosing as a cancer. And we should always take biopsies if there's any suspected ulcer that we think might be cancerous. So complications of H. pylori, things to be aware of really. Most of them will be asymptomatic with mild chronic gastritis. Some develop symptomatic gastritis. Some of them will develop peptic ulcer. Very few minority can develop gastric carcinoma as a result. Another very small minority can develop gastric lymphoma. So, your point. I say the most important points are to know these NICE referral guidelines. These do come up in exams, and they're very important to know about in general practice, and like not GP but general practice. So, if someone had dyspepsia and significant acute gastrointestinal bleeding, refer them immediately to a specialist. And immediately to a specialist on the same day for endoscopy. And again, any patient over 55 years of age who has weight loss plus either dyspepsia, reflux, or upper abdominal pain for endoscopy within 2 weeks, and that's because we're suspecting cancer. So this is acute hemorrhage, and this is cancer. Endoscopy is the gold standard for peptic ulcer. Peptic ulcers have a spectrum of severity, so just be aware of the different symptoms. And yeah, I just mentioned some of the key risk factors are GORD, H. pylori, and NSAIDs. Okay, so quiz time. I know you all love SBAs. So, a 78-year-old female is admitted to hospital with a 1-day history of fever, diarrhea, and vomiting. Her past medical history includes a recent hip operation 2 weeks ago. On examination, there is widespread abdominal tenderness, guarding, and abdomen is distended. Urgent blood and culture are sent. Which of the following investigations should be performed next? Is there a pregnancy test, a chest X-ray, colonoscopy, stool sample, or abdominal X-ray? Okay, I mean maybe I've written a poor question, but so what? A lot of you here have gone for E, which is an abdominal X-ray, and then the next group of people have gone for stool samples. Okay, I'll go through my explanation for the question, but I see a lot of you, because a lot of you have gone for E. I'm going to say that is one of the possible answers. So the answer I went for was a chest X-ray. The reason being is because we if you look at this patient, we think this patient has developed peritonitis. They've got abdominal tenderness, guarding, and their abdomen distended. So we think they've got peritonitis and we're quite worried about them. So the reason I've gone for chest x-ray is because we want to check the pneumoperitoneum because you want to exclude a perforation. This patient might have developed this patient probably has had gastroenteritis that led to a septic infection, and we're scared of perforation. So we want to check for air on the diaphragm, like you might see here. You wouldn't do a pregnancy test because they're outside the reproductive age. Let's see, sorry. Start PPI. We haven't. Sorry, oopsie. You didn't see that. You wouldn't do. Let's see. Colonoscopy. Patient's unstable, and then the risk of perforation if you do that. Stool sample. You might do that, but it's not the first step in management. This patient is probably not very well. They've got abdominal tenderness guarding and the abdomen distended. You probably wouldn't go straight for a stool sample, and that's going to take a while to get the results back from. An abdominal x-ray is a good idea, and you probably request that they have chest x-ray and abdominal x-ray together, so I'm going to say that's basically correct. And that will be able to tell us if they're dilated glutes bowel, and if there's any toxic colitis. It won't, however, show perforation, but you'll be able to see if there's high levels of edema from the abdominal x-ray. Okay, so you may have seen the answer to this one already. 50-year-old male presents to a GP. He complains of heartburn symptoms and epigastric pain for the last 2 weeks with occasional vomiting. He described that the heartburn gets worse on lying down and his epigastric pain worsens after eating. He has occasionally vomited blood. He works as a nurse and has late evening meal just before bed. His drug history reveals he has been taking ibuprofen to manage his pain. What is the first step in his management? Well done, guys. I might have given away the answer already, though. But yeah, well done. So the answer is stop the ibuprofen. So this patient, we've said, has lightly developed peptic ulcer because of GORD. Sorry, I'm not good at doing this. We can see they've got symptoms, of course. They've got heartburn. It gets worse after eating and worse when they lie down. You see he has late meals as well. So he's got a lot of symptoms that suggest GORD. And he's also got peptic ulcer symptoms such as epigastric pain and vomiting. So yeah, and he's probably got an esophageal ulcer as a result of that. So triple therapy, we wouldn't treat. We wouldn't do that unless we know the patient has confirmed H. pylori, or the PPI therapy has failed for about 4 weeks. Routine endoscopy would not be the first step. You'd only do that in patients that we have a suspected risk of cancer. And you suspect might have cancer. This patient will probably put back on PPIs. We'll probably start PPI. That's not going to be the first step. And urgent endoscopy would only be recommended in someone with severe hemorrhage or has suspected gastric cancer. Okay, so now it's time to take a break.
Thanks for watching. Don't forget to like and subscribe. If you're watching this on YouTube, head to our website to watch the next part. If you're already there, just mark this part as complete.